I'm Megan Douglas, Vice President, Customer Relations and External Affairs at Saskatchewan Blue Cross. And on behalf of our entire organization, we are delighted to be here with you as an ally to the We Rise conference. Thank you for joining this essential dialogue. Conversations like these help our communities connect and grow through understanding. As an organization deeply committed to advancing the health and wellness of all Saskatchewan residents, we place great value in the opportunity to be here with you today to help contribute to the healing of First Nations communities in our province. It is both an honor and my pleasure to introduce to you Dr. Alika Lafontaine, who will be speaking about truth before reconciliation in health. Dr. Lafontaine is Cree Métis and Anishinaabe Polynesian, born and raised in southern Saskatchewan Treaty 4 territory. He is an award-winning physician, an inspiring speaker, an alignment consultant, and the first Indigenous physician listed by the Medical Post as one of Canada's 50 most powerful doctors. I have no doubt you will find his words and stories powerful. Here is Dr. Lafontaine.
It's an honor to participate in the We Rise conference today, specifically to talk about systemic discrimination in healthcare, and maybe provide some advice and nuance to add to the conversations you're having today. My name's Alika Lafontaine. I'm an anesthesiologist by training. I was born and raised in Treaty 4 territory there in southern Saskatchewan. I have Cree, Anishinaabe, Métis, and Polynesian ancestry, and I've been involved in health transformation for the past 2 decades. This is one of my favorite pictures from residency. That's my mom there on the side. She came by on the very first day that I officially was on a rotation in the hospital as a real doctor. And you can see the subway in my hand. We sat down and had lunch together that day, and she expressed just how proud she was to have her son kind of move on to the next phase with his medical training. And we circled back to conversations that we'd had many times over the past few years before that, talking about the effect of racism and discrimination and some experiences that she'd had in the past. You know, one of the things that my mom has always expressed to me was how important it was that she had someone within the medical system that she could trust and talk to when it came to experiences that maybe weren't as positive as they should have been, to help give her context and understanding. And I'm hoping that in the course of having this discussion today, I can provide the same for you. There's 4 things that I'm hoping to cover off in this presentation. The first is discussing a world out there that we don't see. The second is to discuss beliefs and racism in healthcare. The third is why the status quo seems to stay the same despite good effort and good work by good people. And finally, what we can do about it to try and create a different future. So there's this world out there that we don't see, and there's a term that we learn within medical school called scotoma. It refers to an area of your field of vision where you just can't see something, so a blind spot or a partial loss of vision. This can be because of some condition that you were born with. It could be because of a progressive neurological disease, or maybe you had some sort of injury to your eye. But for whatever reason, even though something's right in front of you for you to see, it's very difficult for you to see it because it's in your blind spot. I'm going to illustrate this with a couple of exercises, and there's not really any tricks here. I mean, the instruction of count the F's is really what I want you to do right now. It's often nicer to do this in person, but hopefully you can still get the intent and insight that comes out. So I'm going to show you a paragraph in just a second. I'm going to give you 3 seconds. I just want you to count through the F's. So here's the paragraph here, and I'm going to count to 3. 1, 2, and 3. I'm going to move to the next slide, and I'm going to ask you how many you saw. So just be really honest with yourself, and I'll start off with the number 3. So whether or not you saw 3 F's. I'll then move on to the number 4, whether or not you saw 4 F's. And then I'll move on to numbers higher than 4, whether you saw more than 4 F's. So I'll show you the paragraph one more time. And these are the F's here. So you count them: finished, that's 1, files, that's 2, are the result of, that's 3, years of, 4, scientific, 5, study combined with the experience of, 6 years. There's really good reasons why you might have only seen 3 F's or less than the total number of F's that were actually there. The first one is that when we read, we're often taught to read aloud. So as you were reading through the paragraph, a lot of the sounds that you heard, things like scientific versus of, don't really line up with the letter F. The second is that we're taught to read for content. So although I assigned you a task to count the F's, you're probably reading through the paragraph trying to figure out exactly what the paragraph was about. So even though we're told to do something, we often do what we're used to doing. And what we're used to doing is reading things to understand what they mean. The final reason that's common for not seeing all of the F's is that we skim to be efficient. So big words equal content to us, while small words equal filler. And so we tend to focus on words like scientific while skipping over words like of, especially when we don't have a whole lot of time. I'm going to have you go through one more exercise, and this is reading the triangles. Once again, there's no trick here. Just kind of read the 3 triangles that will be across the screen there. I'm going to give you 3 seconds again, and we'll just turn here. You can read triangle number 1, triangle number 2, and then triangle number 3. And I'm going to ask you to read them one more time. And just be honest with yourself about whether or not you saw what was actually in the triangle. So for those who are looking at it and can't see, the first triangle says parents in the spring. The second triangle says once in a lifetime. And the third triangle says bird in the hand. So these scotomas not only happen to our physical eyes, they also happen to our mind. And these are called intellectual scotomas. They're an inability to perceive distortions in perception that are obvious to others. And so in philosophy or politics, a person's thoughts or beliefs might be shaped by an inability to appreciate certain aspects of social interaction or institutional structure. So bias is something that we all have. It's a way that we apply distortions to the world. They're the scotomas that we live with day to day. These aren't things that we can necessarily get rid of. Bias is always something that we manage because it's something that we're taught from when we were very young and reinforced as we get older and older. Discrimination is when you project those biases or those distortions onto other people. And those distortions can be based on race, gender, age, socioeconomic status, etc. Now, an ism, or something specific like racism, is when you add discrimination and connect it to a real or threatened loss of opportunity to real or intangible resources. So bias is something that we're all born with. Discrimination is when we project those things onto other people. Racism or the other isms are when we take that discrimination and we use it as a reason to take something away or not give someone an opportunity to do something. So racism specifically is when that discrimination is based on race. And once again, it's always linked to a loss. Now, all of this ties back to colonialism, because colonialism really was a system that was designed historically and contemporarily to remove the rights to land and resources. And so it's the use of racism in order to justify the loss of access to land and resources. And so whenever we talk about systemic discrimination or bias within healthcare, and specifically systemic racism, the real important part to focus on is, what do people lose? Do you lose the opportunity for access because of discriminatory practices where access to healthcare is not provided? Do you lose access to options because people look and say, well, you're from this race, or you're this gender, or you look like you're from this socioeconomic class, and you wouldn't want to do these things, or you wouldn't have access to do these other things properly, and you just don't have the choice. And this, once again, always ties back to these colonial systems that we inherited. So I'm going to talk a bit about beliefs in racism in healthcare, using those concepts and kind of building on them.
Yes, I have experienced racism in our system with the doctor here and nurses. Nurses, treat us differently. My file, every time I go there, like, I'd be there before everybody, and I thought it's first come, first serve. But my thing would get, my file would get put to the bottom. You know, I'd have to wait there all day, and you know, I'd be trying to talk to one of the nurses, or talk to the doctor. You know, then they'd tell me, go sit down, like telling me to go sit down like a child. You know, I'm not a child, and then not wanting to speak to me, and then I see someone goes up right after me, like another patient. And they talk to one of them right away, and like they tell me they're busy, and that's with the doctor and nurses that they do that. Well, for the one thing, I'd like a different doctor. Plain and simple, a different doctor, and also better training for people skills for the nurses. They seem not to have any people skills, They get grouchy at us. The woman that sits at the desk that takes some names and, sets us up, she gets grouchy with us. When I was there 2 weeks ago, I heard her swear and say effing natives. I heard that. I was sitting right there in that chair. She kind of whispered it, but I heard it. I heard it clear enough to make out effing natives.
Well, I know when my mother was in the hospital, she had diabetes and she had, like I said, heart, kidney, and lung problems, and she was in the hospital for about a month or maybe even 2 months. And when I went to visit her, she didn't have no sheets on her bed. They told me that she was on a mattress that didn't need sheets, but when they finally came to check on her, it was not that kind of mattress. And my mother wouldn't say anything. She wouldn't make any kind of fuss. She just laid on the rubber mattress, and that's it.
I'm a diabetic, and the one you're talking about, he likes touching women. He even done that to me too. And I used to wonder, is that possible for a doctor to do that? Eh? He slipped his 2 hands into my panties, but didn't touch my private. He done that from the back to the front. Eh? Boy, I was amazed when he just threw himself on the chair after he got that. And he was just blushing, just red. Eh? I just about swore at him, but then again he might charge me. I should have swore at him at the time. I tell him the same thing what I experienced with him. Are they going to do anything about it? Probably like that. The time I broke my knee, and then when I was there for 5 days, and the nurse was coming to give me 4s, and then I told her, can I get a Tylenol extra strength instead of it? She got mad at me, and she went back to that word she keeps her pills to come and give me that Tylenol thing. And she holds my lips and then puts that pill into my mouth roughly. And I told the other nurse to put my leg on that pillow. She lifted my leg, put the pillow there, and just dropped my leg. I was just being treated. If I was able to walk, I said I would have walked out of there. And I told my auntie, though, she gets the same treatment.
Well, a lot of old elders don't feel safe there. Like, I see elders when they're in a hospital. Like when I go up there from that time, I talk with them. They don't feel safe. They look scared, but they don't want to say anything. But they look scared, and you can feel that on them. And that shouldn't be these are our elders. They shouldn't be feeling scared like that. That's a place they should feel safe.
Kinds of things should happen. We should have proper diagnosis. We should have First Nation people at the doctor's office, the drugstore, throughout the system there. We should have a place for concerns to be heard, anonymity, and also online questionnaires or something to that effect where a person can actually to sign in and say this is what happened to them.
He's the only doctor we can see, so like what if we're really sick one time and he doesn't want to give us treatment because of that? And he will do that.
And that nurse there, that receptionist at the hospital, she used to be very friendly with me. Now I'm mad to her, I guess. For what, I don't know. You should see the way she treats them, very negative and looking angry. I just about told her the last time, why don't you quit your job if you don't like working for Indians? I just about said. I will do one of these days.
So that video is never easy to watch. I've presented that hundreds of times across the country, and it's always interesting looking into the audience and seeing the reactions of people. I imagine many of you there today have probably experienced the very things that were shared today. And when I talk to providers, specifically physicians, about these lived experiences, I use this quote just to illustrate the way that providers are conditioned to react to this. You know, our stories are so out of norm and removed from others' experiences that those others have a hard time believing that these things could happen. They believe these experiences are extremes, while this is actually our status quo. For those of us that live this reality, the status quo is no longer an option for us, our children, or our communities. I imagine there's many of you who may be watching this right now who have experienced this in your own interactions with the healthcare system. So the question that I'd ask you to reflect on is, do you believe these stories? And I imagine that if you've experienced them, of course you believe them. But if you're here as somebody who's learning about systemic racism or discrimination, do you believe the stories that were shared? And when you look around you, especially within those who hold decision-making positions within the areas that you work in, do those decision makers believe these stories? You know, there's been a variety of different experiences that have come out into the news over the last decade or so. You know, there was Brian St. Clair in 2008. There's Joyce Echaquan, who recently came into the news in, you know, the fall of this past year. And I'm going to focus a bit on Joyce's story because it illustrates kind of these concepts that we've been talking about up until now. So for those who are aware of what happened to Joyce, there was worldwide awareness of her experience because she started streaming a Facebook Live that went viral at the beginning of a Monday. The video lasted for 7 minutes and 12 seconds. It was turned off by a nurse who became aware that she was streaming. And the reason why she started streaming is because she had gotten into a habit, along with family members and friends, that they needed to stream their healthcare encounters just to make sure there was some sort of record of the negative experiences that they were having within the healthcare system. So in the video itself, and it's a very tough video to watch, she screams for help throughout the video, and the providers who are there on the live stream can be heard saying a variety of different things. I've written them down here, but I'm not going to repeat them. And at the end, when everything gets turned off, Joyce dies a few minutes later. You know, there's beliefs that Indigenous people don't care about their health. The belief that Indigenous patients won't understand explanations. You know, the term non-compliant. You know, you won't listen to the advice that I'm giving you or the things that I'm telling you to do. Drug or alcohol abuse being listed as very likely diagnoses, even though often when people come in with confusion or disorientation, there's a lot of different things outside of drug and alcohol abuse that it could be that, you know, are things that really should be investigated and worked up. Projections onto Indigenous patients that they're aggressive or disruptive, beliefs about cultural or genetic predispositions towards sickness. And then because of all of these factors, having the idea that somehow the health system or providers need to be more paternalistic because people can't manage their own lives and their own care. So the first column of one-off harm asks the question, was Joyce the victim of racism? And I think for anyone who watches the video, it is very clear that she had significant mistreatment, that there was racism that was a part of it. If you believe that Joyce was the victim of racism, then you must also believe that the providers failed to provide an adequate standard of care. And if you believe that, then the failure to provide that adequate standard of care should then lead to a connection between the care that was provided and the harm that occurred, and that there was a contribution towards her death. Now, if you ask the second question about repeated harm, you have to question and investigate whether or not Joyce suffered a consistent pattern of racism over time. Many of us who've experienced racism within the healthcare system know that the first time that it comes out that you've experienced racialization is very unlikely to be the very first time. And so, the question that they're asking in investigating the experience of Joyce is whether or not she had more than one event that occurred like this. Now, if this is a belief that the system commits to, providers then failed to provide an adequate standard of care in multiple instances, and that the aggregated harm over time due to racism had an impact on Joyce's long-term health, wellness, and eventual death. That it wasn't just this single experience that she had. Now, when we talk about systemic harm, it really centers around whether or not we believe that other racialized patients suffered a pattern of racism over time. Whether this just wasn't Joyce, this was others as well. If this belief is something that we believe in, then we must believe that racialized patients are treated by providers with an inadequate standard of care, and that this aggregated harm over time due to racism has an impact not just on individuals, but also indigenous communities and their health, wellness, morbidity, and mortality. Sometimes it's not clear to patients, and sometimes to allies, the real impacts that each of these beliefs has on the health system. And so if the belief that this was a one-off event, that Joyce suffered harm, and it was only Joyce that one time, the impact of that belief is that the perpetrators will be punished, which is what happened in this case. The providers who participated in her care ended up being fired. And the health system likes this type of solution because it's a simple, low-cost option that requires just a really brief realignment of accountability, resources, and responsibility. Just a little bit of disruption that's really just focused on a small number of people. Now, if the health system acknowledges the belief that Joyce suffered a pattern of harm, then this has different types of impacts. Not only the perpetrators who caused the harm need to be punished, but also those who had responsibility and accountability for the perpetrators, those who oversaw their care and their training, need to be involved in the punishment as well. This ends up being a bit more complex, but it's still a fairly low-cost solution that requires just a temporary realignment of accountability, resources, and responsibility within health systems. Now, if the question of systemic racism is acknowledged, and the health system acknowledges that persons like Joyce suffer the same pattern of harm, that leads to a very different impact than the first two. There's the need for the health system to reconcile the ongoing loss to access of care and the effects on health and wellness being suffered by Indigenous peoples, communities, families, and individuals. This is very complex and high cost, and it requires a permanent realignment of accountability, resources, and responsibility. And so when you consider each of the different impacts, I hope you can start to see why the health system, or systems in general, within education, social justice, and health systems, are very resistant to kind of the systemic label versus the individual one-off label. Each belief has a different system impact. Going back again and talking specifically about what happened, If Joyce suffered harm, the perpetrators would be punished, staff would get replaced, but local leadership would still be the same. If Joyce suffered a pattern of harm, then you'd punish those who had responsibility and accountability, as we mentioned before. Staff would get replaced, local leadership would turn over, but high-level leadership would more or less stay the same. Now, if you believe the systemic nature of these things, persons like Joyce suffered the same pattern of harm, you'd once again have to reconcile the ongoing loss to Indigenous communities. But then everyone, from local staff to high-level leadership, would have to reconcile their accountability and responsibility, not just in the episode that Joyce suffered, but also all the historical and future harm that happens against Indigenous people. And so the impact of these different types of harm gets bigger and broader as you move towards systemic patterns versus one-off patterns. And that's one of the reasons why the status quo tends to stay the same in systems, because it's much more straightforward just to blame an individual than it is to blame a colonial structure that we all inherited. And so this brings us to the next question of why does the status quo tend to stay the same? So the question that I'd ask you is, what is the impact to you if you believe the stories like Joyce? What is the impact to those around you, especially those who are decision makers, if they believe these stories? And going again from that continuum of, a one-off situation to a single person experiencing a pattern of harm, to a systemic pattern of harm against persons who have the same sort of characteristics. This is something called the Kubler-Ross change curve. It's something that I use lots when I'm teaching health system leaders about system change. And it goes through the different stages of change within a system. You start at number one where things are neutral, they're status quo. Something occurs where there's some excitement that then triggers some sort of change. As the excitement leads into the actual change, people within the system start to deny that a change is necessary. If you can get past that denial, you then move into a phase where there's a lot of resistance and the attitude starts to turn to the negative. If that resistance can be overcome, then people start to get used to the idea that they need to explore this change. And then over time, people start to get committed to a new way of acting within a system. Now, if you look at the crises that happen within our communities, specifically experiences of racialization, those are often the things that trigger, changes that need to happen within the system. The experience of Joyce triggered a national conversation where leaders from across the country were brought in. I was invited to attend both of the meetings that kind of discussed the experiences of Joyce and some of the plans to address it moving into the future. And as things are moving through the change cycle, we're now getting pushback where people are starting to deny that things are a problem and resisting the change. And it's tough because we don't often reach this point of transformation around the exploration phase. And instead, the system and the status quo push us back through the crisis again to almost reset all efforts. These national conversations around racism and discrimination and bias are not new. There's been many national conversations that we've had many times about many different patients. But for reasons that I'll go through in just a moment, the status quo is very strong at using both denial and resistance to ensure that we never get to transformation. Insights from past national projects are that denial really centers around the following questions. So for an individual to actually acknowledge that racism exists within the health system, they often ask themselves the question, sometimes even unconsciously, what does acknowledging systemic racism mean for my identity? The things that make me who I am. An example would be a medical provider. If I acknowledge that racism exists within the areas that I work, what does that mean about me as a person? Does that mean that I'm a racist physician who creates harm? And how do I reconcile that with the identity that a lot of providers have where, they're good people who are trying to do good things and create better outcomes for the patients that they treat? What does acknowledging systemic racism mean for my self-worth? How can I value who I am in the world if I'm part of a racist system? I don't think we often talk a lot about the reasons behind denial for providers within the different systems that systemic racism exists within. Providers and, our identities and self-worth and value and, police officers and what being within a racist system means for them, social workers, other persons who provide frontline services or care. And although the struggles with identity that providers and frontline workers go through shouldn't be confused as equivalent to the pain and suffering that persons who actually have lived experience being victims within these systems, people who actually experience racialization within these systems experience. If we don't unpack these things around the reasons behind denial, it becomes very difficult for us to move past those phases within the Kubler-Ross curve. If you're able to help people to start to reflect on what it means for them and what they believe about themselves, and you get into the resistance phase, there's different questions that then come up at that point. People ask questions about what will happen to the power that I have within the system if I acknowledge systemic racism. How will my accountability change? Who will I answer to? What kinds of effects will that have on my day-to-day work? Will I still have the same sort of resources to access if this change occurs? And how will my responsibilities and actual workload shift as I move forward with the change? And once again, these questions aren't equivocal to the pain and suffering that people go through when they have racialized experiences within, social justice, education, and health systems. But if we're looking to see how we move past and have a different type of conversation, they're very important things to unpack as we work with allies and persons who are open to having these discussions to help you frame, how exactly you go about creating change in an area that's actually very, very difficult to change. I go back to the conversation that I talked about with my mom and how one of the things that she really wanted to know was context and insight into her experiences. How could she navigate things differently? How could she understand the mindset of the person who's across the table? How could she advocate for herself? How could she help that provider see her as a person instead of this caricature that was being projected onto her? And these are really important questions to navigate towards having that opportunity. Often what we do within the Kubler-Ross change curve is intuitively we know that denial and resistance are the things that we have to break through in order to get to the transformation. And we think that if we just push really, really hard and break through that barrier, that somehow we're going to get to transformation. But the reality is that force in complex systems often isn't effective because the system's much more experienced and resourced at pushing back against your individual force than your individual forces at breaking the system. And so one of the ways that we often try and break through the system is through, traditional tools of transformation. I'm sure some of you may have been involved in projects like this where, you organize a committee, that committee writes together a draft framework, that draft framework goes out for consultation, that consultation then gets written up into a draft report, which then goes out again for a second kind of round of consultation. after that consultation comes back and people kind of sign on and say, yeah, this is a good idea, you then publish a final report that you then publish and really try and promote people to adopt your recommendations. I think one of the struggles with this type of approach is that it usually doesn't work. And I say this as somebody who's written, scores of reports with scores of, recommendations. Often it's the one-to-one relationships that you develop and the strategies that fit between the public promotion and adoption of these recommendations where the real change occurs, not necessarily in adopting the recommendations themselves. And so this brings me to the final point in the presentation of what can we do in order to push through this status quo that's so very good at resisting change. So once again, going back to the denial and resistance, I'd ask you to consider these two statements. The first is related to denial. Individuals and systems will always resist beliefs that make them irredeemable villains. And so I'll be specific here that it's not that you can't say that people have done bad things. It's not even that you can't say that people are bad people in the way that they act. But it's hard for individuals and systems to accept the belief that no matter what they try and do, that no matter what they learn and try and grow, that they can never change. And that's really the core that I found through my experience over the last couple of decades. That when people are going through denial, they want that space where they feel that they can change. One of the things that I've really appreciated when we use the words truth and reconciliation is that reconciliation is really about someone becoming something different than they were before. Evolving and shifting and changing their mindsets and being able to engage and have relationships with people that they harmed in the past, whether it's big or small, and actually have a different type of relationship. By definition, that actually means that very few people then are individuals who can't change. The second statement that I'll ask you to consider is related to resistance. And that's that individuals and systems will always resist change that makes them disempowered below a certain threshold. I think one of the things that's often very alluring with pushing through change, especially when there's been, hundreds of years of disempowerment that have been suffered by individuals and communities as far as systemic racism and discrimination, is having other people feel that same sort of disempowerment. And I think that those within power positions, there's a threshold where that disempowerment goes too low, to the point that they'll actually fight very, very hard, to the point of, using all their different resources to push back, to ensure that they don't get to that point. And it's interesting when you consider, the teaching that we've inherited. Things like courage and love, wisdom, honesty, respect, humility, and truth. And that living a good life and who we actually are as Indigenous people actually creates a situation where, these statements aren't really where our philosophies and traditions and teachings take us to. But often in the situations that we get into as we work through change, we get pushed into these areas because of the effects of colonization that have happened to us. This is a quote that I really love. We want to take back our education and teach our history, our language, and our culture. We have begun to tell our story, our history, and we want to tell it in our own words to the world so that this will never happen to any of the other nations in the world. At the core of living a good life and being who we are as Indigenous people is applying these teachings in a way that not only prevent ongoing harm to us, those who suffer from systemic racism, discrimination, and bias, but also making sure that the negative effects of these things stop happening to other people as well. When I do my work and practically apply, moving forward in this good way, I use a set of steps that's a little different than that framework that I showed earlier. The first step that I usually focus on within these projects is developing hope that change is possible. And I think that that's something that's you're going to see grow within the next few days as you go through this We Rise conference. You have an opportunity to take this hope that you're generating and actually create spaces where empathy and inclusion can exist, where people can sit back and realize that despite all the things that happened, they can change and become better people. The video that I showed earlier that talks about the patient experiences, one of the things that I've realized over time that's really, really important to point out to physicians in particular that watch that video is that I'm not trying to tell people that they're bad people. They may be doing bad actions, but at their core, that doesn't necessarily mean that everything about them is bad. We've all inherited these systems of colonization, these beliefs and schetomas on how we treat each other. And the weight of history should not be borne on everyone's shoulders as far as creating these systems that enabled this discrimination and racism. When we become aware, though, it is our responsibility to make sure that we stop that from moving forward. And I think as you sit and you talk with, different participants here today, especially if you're someone with lived experience who's working with someone who's trying to learn how to be an ally or trying to learn or unlearn the things that they've kind of inherited through these colonial ways of thinking that have created harm. Having empathy and inclusion for them will accelerate your ability to move past that state where the harm's occurring to now talking about how the harm can stop. There's other steps that come after creating these safe spaces, asking about the value that stakeholders can provide to the ongoing mission, making sure that there's some sort of value exchange that's not just an MOU, but also moving back and forth resources, information, people, etc. Making sure that you get that commitment and then using those resources to act, to move forward and actually change the things that we're talking about today. The system's not broken. It works exactly how it was designed. The status quo is based on colonized systems we've inherited, and it decides who has opportunity and access. Denial and resistance are why status quos stay the same. But hope, empathy, truth, and reconciliation can change us all into better versions of ourselves and help take us to a different type of future than the one that we've experienced in the past. I'm always grateful for opportunities that I have to share my own experience when it comes to systemic racism, discrimination, and bias. And I hope that as you move forward over the next couple of days, you reflect on your own beliefs and your own blind spots, and also those of the blind spots of people across from you, and share your truth, but also leave some space open for empathy and space for people to change. Reconciliation is always two-sided. The person who's harmed changes and grows. They become more confident at sharing their truth. They start to realize and grasp the power that maybe was always there, and moves out of these systems that create these myths that somehow we can't do or change things ourselves. The person who created the harm starts to realize that, the way that they've been acting isn't really bringing them to the end stage of achieving what their outcome is. As providers, we don't want to harm patients. I've never met a single provider who has ever said to me, if I go to work and just, racialize a patient, that'll just be a great day. I also imagine that for police officers, social workers, persons who work within the justice system and prison system, those types of sentiments are things that probably are common among those within those systems. Thank you again for the opportunity to participate in this We Rise conference. It's been an honor, and look forward to further discussion later on today. Thank you.
Hi, I'm Tavia Lullery from SIT. SIT is proud to support the first annual We Rise conference and the efforts towards a strategic action plan for change in relation to murdered and missing Indigenous women and girls and the calls for justice. It is my pleasure to introduce Métis fiddler Jordan Daniels with dancers Michelle Leniak and Kayla Montgrant. Dancing has always been a part of life for cousins Kayla and Michelle, who have been dancing to Métis music since they were kids. Kayla is a member of the Creeland Dancers, who specialize in a fusion of Métis jigging and square dancing, focused on First Nations and Métis cultural enrichment and reconciliation. Jordan Daniels has been playing Métis fiddle music since he was 10 years old. He's a 5-time Saskatchewan Junior Champion at the John Arcan Fiddle Fest and has performed with the Regina Symphony Orchestra and across Western Canada in many events. They will be performing a first change into the Red River Jig into Big John McNeil. They feel privileged to perform in honor of murdered and missing Indigenous women and girls.